Welcome everyone to our virtual 2021 PWS Family Conference presented by Soleno Therapeutics. Before we begin today's presentation, let's first thank our amazing sponsors: Soleno Therapeutics, Levo Therapeutics, Harmony Biosciences, Radius Health, Inversago Pharma, Saniona, Conscience Therapeutics, and Novo Nordisk. Their support allowed us to make this conference free for all our community members, and we are incredibly grateful for their contributions. In this session, Strategy for Managing Behavior and Anxiety, Dr. Tony Holland will discuss strategies for effective management and will touch on recent research that shows promise in improving the behavior profile in PWS. Tony Holland is a distinguished psychologist with expertise in the area of developmental and intellectual disabilities. His clinical work has been as a consultant psychiatrist with the Specialist Learning Disability Services. His specific research interests include the eating, behavioral, and mental health problems associated with Prader-Willi syndrome. With colleagues, he has published research extensively on these topics in academic and practice-based journals. He is a patron of the UK Prader-Willi Syndrome Association and president of the International PWS organization. In 2010, he was elected a Fellow of the UK Academy of Medical Sciences. In 2015, he was awarded a CBE and the Queen's British Birthday Honours for service to psychiatry. Since 2015, he has held an emeritus position at the University of Cambridge. Without further ado, I welcome Dr. Tony Holland.
Thank you very much, Melissa. It's a pleasure to be here. First of all, really, I'd like to thank FPWR for asking me to give this talk. It's a great pleasure to contribute to this family conference. I mean, it goes without saying, you all know this. I mean, FPWR has contributed enormously to the welfare of people with Prader-Willi syndrome through their funding and their promoting of research. And research is the key to innovation and to new interventions. So I hope this talk will stimulate your thinking and help you support your own son or daughter with Prader-Willi syndrome. During the talk, I have 3 polls, and I'd like to start this talk with the first of these. So we'll have that first, and whilst we'll be looking at the poll, I would like to just mention, whilst you're doing this, that I've sort of reflected a lot on what I should talk about in this talk. Because you'll see from the title, I've been asked to talk about behavior management. I've also been asked to talk about our work on vagus nerve stimulation. The problem, however, with any talk on behavior is that it's complicated and there are no straightforward solutions, and interventions may be environmental, psychological, or medical. And these interventions are often not directly with the person with Prader-Willi syndrome, but with those who support them. What I think I can best do is really give you what I would call a conceptual framework for how you might understand the problem. You are the experts when it comes to your own son or daughter. The way I can help is really to try and give you some of the theoretical thinking around why people with Prader-Willi syndrome engage in the behaviors that they do. So I hope, whilst I've just been giving that general introduction, yes, you've had the chance to complete the poll. Now, you might guess the reason I asked this question is because I did anticipate that mental health and behavior would come out very high up, way above all the other things. And I think we see this time and time again. And in the International Prader-Willi Syndrome Organization, we hear the same thing from people in other countries across the world. And partly for this reason, the International Prader-Willi Syndrome Organization has set up a special mental health initiative where we're bringing people together from all over the world to try and look, from many different perspectives around this particular issue. Now, this is the outline of the talk, but I want to start by making a very clear statement that, of course, people with Prader-Willi syndrome have many strengths, and these are often well illustrated on social media, on websites, on the film that was shown just before this talk started. And I say that because as a psychiatrist, I inevitably are going to talk about things that may be seen as rather negative. But that's because that's the reason we're here. We're here to talk about the behavior problems, but it must always be seen in context. Also, I think the other important thing to say right at the beginning of this talk is that the life expectancy and life opportunities for this young baby with Prader-Willi syndrome is likely to be a lot better than it was for perhaps people born 20 or 30 years ago, when really there were serious issues in terms of diagnosis and care and treatment, and perhaps most importantly, understanding. And my own belief is that information is key in supporting people with Prader-Willi syndrome. Here's a young man who was part of our vagus nerve stimulation trial, and I just show him because his life is good. And the reason for that is that he lives in a good, caring environment that understands the needs of people with Prader-Willi syndrome. And there are lots of opportunities, lots of things that he can do in the day, from day to day. And his behavior actually has got much better, and this is the vagus nerve stimulator, got much better since he's had vagus nerve stimulation. And so life has been good for him. And it's important, therefore, that we hold on to this, that whilst there are still many, many problems, and you will know better than anyone about these challenges, I think we are making progress, and we certainly have made progress. Now, what I want to reflect on is what I've called things like terminology and definition, because I think that I noticed you had another talk on mental health. Now, I'm actually going to talk about both mental health and behavior. And the reason I'm going to do that is that behavior is often the way mental health problems can present. So I think we shouldn't separate the two. I think it's important from your perspective that you are aware that when someone's behavior changes or whatever, one should ask questions about whether this might be due to a mental health problem or not. And this will be a theme that comes back repeatedly during my talk. I want to talk about what I've called mechanisms. In other words, what are some of the reasons why we think that the classical behaviors, such as temper outburst, affect people with Prader-Willi syndrome? I believe that by understanding these, then you yourself will be in a much better position to design your own interventions, and you'll understand better why you're often asked to do certain things to try and help someone's behavior. But here, I think there is a key theme that runs throughout this talk, and that in people with Prader-Willi syndromes, behaviors develop and are maintained as a consequence of an interaction between biological vulnerabilities, and I'm going to argue this is about brain development, biological vulnerabilities, and environmental circumstances. In some cases, the biological aspects are very powerful. In other cases, the environmental circumstances are very powerful. But you can't treat or intervene with these behavioral problems without understanding that there is two broad components to understanding problem behavior. I also want to take a step back, really, and look at the World Health Organization definition of mental health. And I'm a great fan of the WHO. I think it's done great work in mental health over the years. And the reason I do this is I want to emphasize that mental health is more than the absence of mental disorder, but it's about the emotional, psychological, and social well-being. And really, it's analogous to physical health. We don't say someone is physically healthy simply because they don't have a physical illness. We think of physical health, being physically healthy, as being about being able to take exercise, being robust in the things that we do. And the same is true with mental health. And these are some of the phrases from this paper by Galtazzeri, some of the phrases that he uses to, in a way, describe the components of mental health. And when you look at these, you can see that, of course, people with Prader-Willi syndrome have real problems with some of these. For example, the ability to cope with adverse events and perhaps always to function socially, or to recognize, express, and modulate emotions, and so on. And you'll see as I go through this talk, these aspects are there in the way I think about some of the problem behaviors, in some of the mechanisms that underpin these behaviors. And I think it's useful having this understanding or this framework for thinking about mental health. Mental health, I use the phrase mental health and mental ill health to refer to not only mental illness, but the behavior problems that people with Prader-Willi syndrome experience. Now, I want to also say that the starting point, I think, for understanding the behavioral difficulties experienced by people with Prader-Willi syndrome is the context in which people live and grow up and develop and become independent. And I use the sort of concept of well-being or subjective well-being. And this applies to us in many ways, but there are certain aspects to this which are particularly relevant and particularly need to be shaped around the needs of the person with Prader-Willi syndrome. And of course, part of this, and this is true for all of us, the way we manage in the world will depend upon our own individual strengths and the types of personality we are and so on. And the same applies to people with Prader-Willi syndrome. It will depend upon our experiences from the past and our present family, cultural and social environments. But there are some things that are perhaps particularly relevant for people with Prader-Willi syndrome. You know, being a healthy weight, being physically active, and all those pictures of young people with Prader-Willi syndrome that were shown in that film, all of them were a good weight, they were active and so on. These things matter. We ourselves take them for granted, but for people with Prader-Willi syndrome, these are critically important in terms of their general well-being and their mental and physical health. And of course, as you are all aware, part of that, or a lot of that, is the living environment and the opportunities that they have that are shaped to meet the particular and specific needs and wishes of a person with Prader-Willi syndrome. And I think one of the themes of this talk is that there may be things about the more biological aspects of Prader-Willi syndrome that you perhaps at this point in time can't do much about. But there are things you can do in the environment that help to compensate for that. And that's where the knowledge is so important. But there's also this bit here, and I've called this dimensions of mental ill health. And the reason that I've called it dimensions is because this refers, and I'll come to this in a moment, to things like the hyperphagia and the emotional outbursts and the skin picking, is that of course these things are dimensional, they're not categorical. Hyperphagia isn't either there or not there. It may vary in intensity. It may vary in intensity in the same person over time. And it certainly varies in intensity across groups of people with Prader-Willi syndrome. And I want to now just explore this in a little more detail. And this is really coming out of the early work of the International Prader-Willi Syndrome Organization's mental health working group, is that when we think about the dimensions of mental ill health specific to people with Prader-Willi syndrome, the starting point is to understand the impact of delayed and atypical brain development. Now that, of course, must have its origins in the genetics, and as yet we don't understand why the particular genetics of Prader-Willi syndrome lead to this atypical pattern of brain development. What I think we do have, not only from observations in terms of cognitive function and so on, but now from neuroimaging, from brain scans, we know more and more about some of the aspects of brain development that are atypical in people with Prader-Willi syndrome. It affects the cortex, which is the surface of the brain, important for thinking and language and so on. Also the structures, what's called the subcortical structures. And as you will be aware, very specifically, this tiny nucleus right in the middle of the brain just there, called the hypothalamus, and its connections. And the hypothalamus, I think I read recently, probably of all the nuclei in the brain, has the most connections with different parts of the brain. It is critically important. And we know, and there's more and more evidence for this now, that the hypothalamus is key to much of our understanding of many aspects of Prader-Willi syndrome, not least, obviously, the growth hormone and sex hormone deficiencies, but also, I believe, mental health and behavior. So really there are, in terms of these dimensions, there are what you might call the cognitive ones, including social cognition and communication, what here I've called behaviors of concern, so hyperphagia, outbursts, and so on, as well as abnormalities of mental state, what I call mood instability, situational anxiety, affective disorders, so depression, or the opposite, mania or hypermania, or psychotic illness. And this may seem a little odd, but I put here that I think one of the things about cognition is often it's missed. And I'll come to this in a moment, in the next slide. But what, of course, alerts us to the fact is that if one does formal assessments of cognition, you identify that people fall outside the normal range or are lower than what you might expect, and IQ perhaps being a good example of that. Behaviors, however, are predominantly observed, often by an informant, whereas mental states are often, you only really identify that someone has an abnormal mental state by interviewing them and talking to them and hearing them describe their own thoughts and mental experiences. And that's important because I think one of the challenges sometimes is to be aware that someone has a problem because they may choose not to tell you or may be reluctant to tell you, and so on. And that's where you as family become very important, because you may be the people that can help me as a psychiatrist, if you like, get inside the head of someone with Prader-Willi syndrome and better understand what's going on. Now, I think it's important just to spend a little time thinking about cognition, and you'll see in a moment how I link the cognitive problems of Prader-Willi syndrome with some of the behavioral and mental health problems. And I'm going to come to IQ in a moment, but there are a whole number of cognitive or loosely cognitive functions or problems with social cognition that you might call higher order impairments. They affect those skills that may not be obviously apparent, but are critically important for survival in a complex, changing and social world. And they become particularly important as people get older. So as a child, you obviously don't have the skills of an adult, but you don't need them as a child. But as an adult, you need the ability to plan, for example, and not being able to set things in the context of time, see things in a logical temporal order and things may be very problematic as an adult. Not being able to recognize accurately the emotions of others may, for example, make it very difficult for you to appreciate the intentions of other people, and so on and so forth. So these higher order cognitive abilities can have a really quite significant effect on the person's understanding of the world, and in turn on their actions. They also may have problems with what I've called educational attainment, such as numerical skills, reading and language, and so on. Now, because of time, I'm not going to go into these in any further detail, but just a note of caution. Many of the studies that Joyce Whittington and I reviewed in 2019 in this paper were done on an older generation of people with Prader-Willi syndrome. And the numbers were often very small in the studies. And there have, of course, been great changes since then. In many countries, there will be improvements in education. And of course, now almost all children with Prader-Willi syndrome, at least in high-resource countries, can expect to be on growth hormone from early in childhood. And all these things, of course, may both improve brain development and improve cognition. And whilst I think these are still going to be problems, they may not be as marked as these early studies indicated they might be. Now, the other issue I think is very important, and I've tried to illustrate it in this slide, and I'm going to illustrate it by just talking about IQ. If you take IQ in the general population, what's called the full-scale IQ, and the tests are set up so the mean, the average of IQ in a group of unselected group of people from the general population is 100. If you look at a group of people with Prader-Willi syndrome, the average IQ is around 60. So it's moved down by about 40 points. But just like in the general population, there's a distribution of IQ within the Prader-Willi population. And this type of distribution may well be true, and is almost certainly true, for many of the other cognitive functions that I've mentioned. The reason I mention that is that, of course, there are going to be some people that are much more able in certain areas than other people with Prader-Willi syndrome. So one has to be very careful not to assume that simply because someone with Prader-Willi syndrome has Prader-Willi syndrome, they will have these particular cognitive problems. They have a high risk for such problems, but it will vary from person to person. And the other point to make here is that, as I think I mentioned a moment ago, that some of these higher order cognitive impairments are hidden. It won't always be apparent that they have these problems. And therefore, it may only become apparent when in certain, say, social situations where they would need to normally call upon these skills, but they don't have them to call upon, that they perhaps act out in terms of their behavior, and it becomes apparent that they are struggling because of some particular cognitive impairment. And that's why formal assessment of some of these functions can be really, really important. So the impact of cognitive impairments clearly may impact on learning and level of educational attainment. And some work that we did suggested too that people with Prader-Willi syndrome do have trouble maintaining their skills over time. So they need to continually rehearse them in order to maintain them. But this is the bit that I think I've become increasingly interested in over the last couple of years. And that is this fact that there's now some very interesting ideas within neuroscience that we humans, what we do is we construct in our brains a model of the world, and we're constantly comparing the environment against that model. And I think, and this is the work of someone called Friston and many other people, and I think one of the struggles that people with Prader-Willi syndrome have is that they lack the ability to reliably interpret and make sense of the physical and social environment. As I mentioned earlier, if you can't fully read someone's intentions, then that's a problem for you. But also, it may affect your ability to respond to and make decisions in an efficient and effective way, and particularly to respond to change. The brain has evolved to allow us to interpret the world in a way that protects us from harm, but also ensures that we obtain the nutrition that we need, and so on and so forth. And I think increasingly we're seeing, particularly in adult life, this is an area that people with Prader-Willi syndrome will struggle with. So atypical and delayed brain development in people with Prader-Willi syndrome. We've talked about the cognitive skills, but I think it does a second thing, which I think, again, we're appreciating is really critically important. And that is they have an impaired ability to what I've just called here regulate. This often goes by the term homeostasis, and homeostasis is the way our body regulates itself in response to changes in the environment. And of course, the most obvious way, the way of thinking about that is temperature. If we're in a cold environment, we shiver in order to maintain our temperature. And if we're in a hot environment, we sweat in order to make certain our temperature doesn't go too high. But homeostasis is also important in terms of energy balance. And the struggle for people with Prader-Willi syndrome is that their food intake doesn't match their energy expenditure. It's more than that. The body normally can regulate really quite tightly that we eat enough to meet the energy requirements of our body. That's in terms of what the body needs as well as what we need for exercise and so on. And this is clearly where things go wrong in people with Prader-Willi syndrome. Now, I'm not going to, because of time, I'm going to turn to some other behaviors in a moment, but I'm not going to focus any more on hyperphagia. But if people want to come back to that issue, I'll be very pleased to answer questions on it later. I also think that we should use this model of homeostasis in terms of how we as humans respond to what I've called threat. Now, threat doesn't mean necessarily serious threat. It may mean change. It means something unexpected happening in the environment. And again, we have evolved to manage that in an efficient and effective way. And as I will argue when I look at the issues of temper outbursts, that this is one of the problems that people with Prader-Willi syndrome have. And I think the same is true of mood, that people with Prader-Willi syndrome have trouble regulating their mood. Now, this model is really focusing very much on the biological, and I will be moving in a moment to look both at the individual problems as well as some of the environmental aspects. But I want to now move to the second pole. So if we go to that at this point, because for me, this is quite a new. When I've talked for many times about behavior and so on in Prader-Willi syndrome, but this is a rather new talk that I'm doing with quite a focus on the brain, and I'm really interested to know whether you think it's helpful. Would you be able to bring the poll up for that?
It is up.
I know you were saying there were some problems the other day, so if it's not possible, it's not.
It is. It's up and running.
It hasn't come up on my screen, but that's okay. So tell me when it's finished and when the results. It's come up on my other screen. Good. Well, I'm actually really pleased. I see that quite a few of you feel it isn't helpful, and 3% of you feel it's neither helpful or unhelpful. Well, that's not that bad, and because, as I say, I give a lot of these talks, and I think it's you never quite know whether it's exactly what people want or not. So thank you very much for that. So what I want to do now is to move to the next slide, and this is really now to focus down on some of the particular behaviors that all of you will recognize are common in people with Prader-Willi syndrome. And there have been numerous studies now over many years from different countries, often using rather different assessment instruments and different techniques. But there's a general consensus that this is, I think, the cluster of behaviors and mental health problems that specifically affect people with Prader-Willi syndrome. The hyperphagia, I would argue, is universal, although, as I mentioned earlier, it may certainly vary in intensity and it may vary in the same person over time. There's repetitive and ritualistic behaviors that are often called obsessive and compulsive behaviors. There's the emotional or temper outburst, the skin picking, what I've called non-psychotic mood disorders. So these are depression and mania or hypermania, and then psychotic illness that I'll come to and I'll be talking about a bit, which is more predominant in people with the maternal uniparental disomy form of Prader-Willi syndrome. So, as I say, there isn't time to focus on all of them. So I've just picked on these, and then I'll end looking at temper outbursts and vagus nerve stimulation, because that leads very nicely into our work on vagus nerve stimulation. And then the talk will finally end looking at terms of some of the implications in terms of treatment and intervention. So I think the starting point here for me in understanding skin picking is again this biological environmental interaction. And I think from a biological point of view, people often refer to this idea of the fact that people with Prader-Willi syndrome may have impaired perception of bodily sensations, what's sometimes referred to as sensory hunger. But they also have increased pain threshold. So the negative feedback that you would get if you or I were picking our own skin almost certainly doesn't happen in people with Prader-Willi syndrome. So there's nothing in a sense that is stopping them with this behavior, whereas this is what, with you and I, pain might well stop us. But I'll show you a study in a moment that suggests that also environmental conditions are very important. So if you're in particular conditions, people with Prader-Willi syndrome may be more likely to engage in skin picking. And there's also the role that these behaviors, and not just skin picking, but particularly temper outbursts, might have as a way of communicating need. And this is the field of what's referred to as either functional analysis or applied behavioral analysis. So the important thing here is to understand the biology, understand the environment, and to understand that the behaviors may continue because of the way that people are responding to them in ways that may actually enhance the fact that they continue or hopefully would diminish them. This is the work of Scott Hall, working in the States and in California, I think. And this is the rates of skin picking in 8 people with Prader-Willi syndrome. And he looked at it under different conditions: ignore, alone, when someone was paying attention to them, and when someone was playing with them, and when someone was interacting with them and placing demands on them. And what you can see is in ignore or alone circumstances, rates in all cases, the rates of skin picking were much higher, whereas in these other conditions they were lower. Now, clearly, you can't ensure that life is completely full with activities, but what this type of observation shows is that there may well be things that you can do in the environment that will actually reduce the rate or the severity of skin picking, in terms of if there's some particular activity. And I was mentioning at another talk recently that I saw someone not so long ago, and she started knitting. And the two things about knitting is, one is it's an activity, but secondly, whilst you're knitting, you can't use your hands to skin pick. So I think that there is a danger that when we look at treatment, we sort of ask the question, is there a medication? When actually we might want to ask the question, is there something that I can do in the environment that will make a difference here, that may reduce, it won't eliminate it. It doesn't change the fact that the risk is there, but it might reduce its frequency. So I think that skin picking really is best understood with this interaction between the biological vulnerability, the physical and psychological factors and environmental circumstances. So in terms of understanding it, you might want to look at over time through observation to see whether there are conditions where it more commonly occurs. And that might help you think through as the parents as to how you might intervene. I think there is indications that, for example, if someone's also depressed, that skin picking may get worse. So if there's a mood disorder, you might want to look to treat that mood disorder. You might really want to look at whether there are environmental changes that can be done. And then, of course, topical treatments to the skin may be important as helping to reduce itch, because we just don't know really what perception is like for people with Prader-Willi syndrome. It could be that, much like with you and I, if a bite or whatever itches, this is a stimulus to pick at it. And then, of course, there's the work of Jennifer Miller, for example, looking at acetylcysteine, which modifies what's called the glutamatergic pathways in the brain. Now, one of the challenges, of course, is these trials have been open trials. And I think one of the interesting observations from many of the studies of agents that are trying to affect the hyperphagia is that placebo effects are quite strong in this population. And I think one of the messages here is that whether it's skin picking, temporal outburst, or hyperphagia, one really does need properly conducted blind clinical trials to really be certain that medications or whatever are effective or not. Now, this may be stepping a little outside my talk, which you wanted to focus primarily on behavior and then on vagus nerve stimulation. But as I mentioned at the beginning, I do think it's really important to appreciate that, of course, when someone with Prader-Willi syndrome becomes mentally unwell, their behavior changes. It may be that fact that alerts you to the issue that there might be something going on. And therefore, I think it's really important that you know what to look for to check whether your son and daughter might have developed some additional mental health problem. The other reason I think it's very important is, whilst of course it would be better that they didn't develop this, it is treatable. But it has to be recognized, it has to be diagnosed, but it is treatable. And I've seen people who've had very serious mental health problems, but they've done very well on treatment. So, whilst some people see this as a rather negative message, I think it's a positive message. But here's a description of the person I saw about 2 years ago now, who became mentally ill very, very quickly, a matter of some hours at the home he was living in. And the best description initially was he became bewildered. But the thing about it was, this was very different from how he had been. He became very much more anxious. He was unable to talk coherently, using odd words. He was referring to blackmail. And initially, as is quite often the case when they're seen in the emergency room or whatever, is that the doctors think this is what's called a confusional state, which occurs with infections, such as urinary tract infections or chest infections. And they thought he might have an infection and they gave him antibiotics. And he improved a little bit, but really things got worse. He started using odd words, grabbing things, reaching out for thinking there was a butterfly there. And eventually he was started on antipsychotic medication, in this case aripiprazole, and did quite well. And over this last couple of years, he's done pretty well, although he has had, I understand, although I'm not seeing him any longer, a couple of relapses. And the thing about this is that this mental illness does appear to be more common in people with the uniparental disomy form. This was the second study we did looking at this, done by Sarita Soni, and there's 85 people with adults with deletion and 34 adults with UPD. And you can see here about 60% either had a history of having had what sounded clearly like a psychotic illness or were mentally unwell at the time. It still did occur in people with deletion, but it wasn't as common. Now, the important thing about this, of course, is it suggests that the causation isn't related directly to having Prader-Willi syndrome, because if it was due to having Prader-Willi syndrome, then you would expect those with deletion to be at a similar risk to those with UPD. It suggests that there's something about having two copies of the maternal chromosome 15 that carries this risk. And we, with support from FPWR, we've got a project ongoing at the present, trying to explore what that might be, so you can get new treatments and better treatments for it. There have, just to summarize, there have been now quite a few studies looking at this from different parts of the world, although the one study that didn't find this was in the States. And I suspect that might be at least partly because quite a few of those in the study were not in the age of risk for psychotic illness. Psychotic illness in the general population begins to happen in early adult life, although in the Prader-Willi population it may occur in the teens. So, and I will right at the end of my talk come back to this briefly, but I think it's just important just to remind you that mental illness in people with Prader-Willi syndrome presents with a deterioration in behavior and possibly the onset of new bizarre behavior. It's often acute, but it can be gradual. It's associated with abnormal mood states and abnormal mental experiences. When it's mental illness, then medication carefully given according to diagnosis can clearly be justified. I think it's much harder to justify medication with some of the other behaviors, and we'll come to that in a moment. But one also wants to look at how you can reduce demand, and careful support is really very important. But as I mentioned earlier on, it is treatable. At times it can take time to get it under control, but it is treatable, and our follow-up study, albeit a small one, suggested the outcome was good, although a small number of people, it was a little more problematic. What I want to do now is move on to the behavior and then to the vagus nerve stimulation. And there's been a lot of studies on behavior, and we know that, as you will know better than anyone, it can be quite severe and can be quite frequent. I think the approaches to treating it include the applied behavioral analysis. I think increasingly we see that food security is important because food security brings a consistency and predictability to the environment. I mentioned, and I think there may be some differences between our countries about this, but I'm a little more cautious about medication here. There may be a role for medication if there's an additional mood disorder or a lot of anxiety. But by and large, I'm going to argue that treatment of temper outbursts is more about the environment than it is about, if you like, a more biological approach. I'm not eliminating those as a possibility. Just two quick examples of studies. This is Rice in Australia. And here she found the behavior in interviews of 101 families got worse in adolescence. We know much more about its course, how it presents, how it resolves. I think we know now that often it's triggered by what they call here goal blockage, the frustration that comes with not being able to do something you want to do, the difficulty dealing with change. And what she found is what the parents reported to her is really the thing that worked most is being able to give space and distract. Medications were being used, but the families generally thought they were of limited value. Then there's the work of Kate Woodcock in the UK, in which she's shown that temper outbursts are often triggered by situations where you have to switch attention, and that requires a major cognitive challenge. And switching attention, you and I take for granted. Something happens, we have to focus our attention on this new thing. For someone with Prader-Willi syndrome, that may be much harder to do than it is for you and I. So it's a much greater challenge. But also, she found that temper outbursts were often related to unexpected change. And she constructed this sort of model that the genetics of Prader-Willi syndrome lead to atypical brain development, this deficit in the ability to switch attention. Unexpected change occurs, you get marked physiological arousal. And she would argue that sometimes repetitive questioning is used by someone with Prader-Willi syndrome to try and, if you like, buy time a bit, but usually they lose it and temper outbursts happen and it has to run its course. And one of the studies that Kate has been doing is, can you train people with Prader-Willi syndrome to prepare for change? And can you help families prepare people with Prader-Willi syndrome to cope with change? Now, I'm going to come back to some of these issues, but I'm going to now move to this issue of the vagus nerve and vagus nerve stimulation, as I was asked to focus a bit on that. And the most recent work we have done in Cambridge in the UK on that was funded by the Foundation for Prader-Willi Research. But the vagus nerve is part of what's known as the autonomic nervous system that is divided into the sympathetic nervous system and the parasympathetic. And the vagus nerve is really the main part of the parasympathetic nervous system. It's the largest nerve in the body, and it connects the brain with the viscera, so the organs of the body, the gut, the spleen, the heart, the lungs. It also connects things like the eye and the pupil and so on. So it influences what I call visceral function, and that's through what's called the efferents, the parts of the vagus nerve that communicate from the brain to the gut, if you like. But it's also important in the satiety cascade, in the gut communicating to the brain that food has entered the gut, is being absorbed, and therefore the brain needs to know that the person needs to stop eating. It's what leads to ultimately this smooth change from a feeling of hunger to a feeling of fullness. It has an impact on immunological function, and this may turn out to be quite important. And importantly, it moderates response to stress. And this is very much in line with the theory of Stephen Porges in North Carolina, what's called the polyvagal theory. And vagus nerve stimulation has now been used for many years, usually in an implanted stimulator, a bit like a pacemaker. And it's been approved for epilepsy and depression, and an increasing number of other disorders such as migraine. And now there's a transcutaneous device. So it stimulates, and I'll show you this in a moment, through the skin. But most of the work over many years has been done with an implanted device. This is the paper from the first study. And this first study was with 3 people with Prader-Willi syndrome who agreed to have vagus nerve stimulators surgically implanted. And the aim of this study was to see whether it could improve the behavior. And the reason for that was, I mentioned earlier, because the vagus nerve is important in satiety. And there's observations that people who've had vagus nerve stimulation for epilepsy, if they happen to be obese, some of them have lost quite considerable amounts of weight. But to cut a long story short, it didn't change weight. In fact, in the first participant, the weight went up and up and up. And we were worried for a while that this might be a unexpected effect of vagus nerve stimulation. But I think what it was is this person, and you'll see a picture in a moment, lived relatively independently at her insistence and is very overweight. And when she had the vagus nerve stimulator switched on, I think she felt, I don't have to try any longer. I can just eat because the vagus nerve stimulator will stop me. This person did lose some weight. This person, the weight remained stable. So much to our disappointment, it didn't seem to help the weight. But and vagus nerve stimulation for epilepsy takes many months to have an effect. But after some months of having the stimulation from the implanted device, the parents and the participants came to us and said, it's not helping my eating, but it's transforming our behavior in 2 of the 3 people. And I'm going to show you this very brief edited film, and you're going to hear from the mothers of these 2 people whose behavior improved, and they had very bad behavior before this, and the father of Katie. And he's going to tell you that it didn't improve at all, although she enjoyed the study. They have, of course, given permission for me to show this film. I apologize that it may be rather quiet and you may need to turn up your volume. And if it is too quiet, then we may not be able to watch it. But let's have a go.
Simon, Jennifer and their parents are keen to share their experiences to help you make an informed decision as to whether this study is right for you.
Big impact. It has changed life at home. It has allowed Simon as well to go out and join in activities and clubs. He has a job, he's in paid employment, it is part-time. I don't think Simon could have coped with that prior to the VNS. He is Mr. Chill, and I'm the only one that shouts in the house now.
It had an impact on her life because she felt more confident after all the travelling. She found the Jesus pool and went swimming and swam a mile, which was a tremendous achievement. And she was proud of that. All those things were very positive. She loved it. I don't think she gained anything from the insertion of the VNS that was positive.
Well, partway through the study, bearing in mind that this time the study was focusing on weight loss, well, we were seeing a sort of plateauing. We weren't really seeing a weight loss, but we were starting to see a huge change in behaviour. And it took us quite by surprise, side effect if you like, but a very positive side effect. We had to sort of think about it quite hard. Was this really happening or were we dreaming? Sure enough, no, we weren't dreaming. It was real. It was happening. All members of the family were beginning to notice huge changes. Jennifer was so much calmer. She was much, much easier to live with. Life was becoming, dare I say the word, normal? Maybe that's pushing it a bit far, but it was fantastic. The change was truly amazing.
Yeah, it's had a very positive impact on my life. You look at me living independently with my husband, that wouldn't have been possible without VNS, so that is one really big thing that it would have definitely not happened without.
And I think that speaks louder than anything I can show you. Of course, it's only 2 out of 3 people, and much more research is needed. And this was the second study, and I'm aware actually the time is moving on, and I'll have to move a little quicker. But this is the one funded by FPWR, and this used the external device that you wear on your arm, and you wear it for 4 hours a day, and it stimulates what's called the auricular branch of the vagus nerve in the left ear. And these were the 5 people that improved. A 6th person dropped out. And the white bar is the behavior before the VNS started. And then at 3-month intervals, so 0 to 3 months after it started, 3 to 6 months, 6 months to 9 months, 9 months to a year. And you can say in these 4 people, the rates of temper outbursts reduced over that period of time. In this person, it didn't. And if you look at some of the quotes people gave, before you couldn't challenge him on certain things, but now you can, and he's prepared to sit and listen. And I think that's, again, very powerful. And if I go back to the model that Kate Woodcock had, I think we can now add this in here, that actually what seems to be really important is this physiological arousal. And what I think VNS is doing is in some way normalizing this. But also I think there may be other psychological treatments that act through changing the response of the vagus nerve. And this is an example of how observations from a trial tell you something about causation. Now, before just ending around some conclusions around intervention and treatment, I'd just like to do the third poll, which is about VNS. I may not be able to see it, so I'm just interested in what you think about it, whether you think it's something that your son and daughter might be willing to take part in. You know, there is the problem that they have to wear this stimulator in their ear. It's a bit like a hearing aid for 4 hours a day. And of course, and we had this, they can have a temper outburst whilst wearing it and throw it across the room. Whereas when it's implanted, of course, it's there and you can't do anything about it. You know, that's the practical aspects. Yes, but maybe difficult to implement. I think that's right. And I agree. I mean, I think, again, I very much agree with the points that you have made here. And thank you very much for answering that. So to end, I just want to say this is, in a way, the conceptual model that I've tried to get over to you. You've got the genetics of Prader-Willi syndrome. That leads to atypical brain development and atypical brain function, if you like, in 3 ways. It impairs regulation, it impairs cognition, and particularly for people with UPD, through a different genetic mechanism, it may increase your risk of psychotic illness. But you've also got all the issues in the environment that you need to look at, that behaviours may be reinforced and maintained over time. You've got the nature of the environment. Is the environment predictable? Can the person with Prader-Willi syndrome, if you like, feel safe in that environment? Are you using visual timetables and so on and so forth that might make this environment more predictable for them? So this is the model I want you to hold in your heads, really. So then you can think about interventions at an environmental level, which are about optimizing the understanding of the person with Prader-Willi syndrome and reducing the uncertainty that they might feel. Structured timetables, visual support, the way you use language. You will want to avoid things like irony and so on and so forth. Food security is very important because of the predictability, and food security is emotional as much as physical security. Sorry, there's something gone a bit strange with this one here. Psychological treatments, so applied behavioral analysis, early intervention in terms of training, but also specific training. How do you help people with Prader-Willi syndrome prepare for change? And how do you work with them? So when an outburst happens, you can help them bring it under control as quickly as possible. And of course, medical treatments for physical illness, such as sleep apnea, that are going to make things worse, or psychiatric illness. Always beware. So as I mentioned, that difficult behaviours may occur for different reasons. So ask yourself, is this what we've seen before, or is it different? And if it's new and different, or it's become worse, ask yourself, is there any evidence that it might be an underlying physical illness or mental illness? Just be careful. I think there are really exciting things in the future. I think certainly in the United States and here in the UK, you've got some very good social care. And I think the more and more you can get social care right, for adults at least, the more important, the more you're going to be able to prevent some of these behavioural outbursts. I think we also need to improve education in childhood and opportunities in adult life. There are, of course, the potential for new treatments of hyperphagia, things like VNS, and potentially treatments for the behaviour problems. Things like oxytocin may be around social functioning. There's going to be changes in terms of personalised medicine and what's called pharmacogenetics. And for me, one of the most powerful things is the application of what I've called neuroscience to Prader-Willi syndrome. How do we better understand the atypical brain development so that we can intervene, if you like, more with the brain, as well as do the environmental changes that can bring about improvement? So I'd like to just acknowledge the fact that our own research has been supported enormously by people with Prader-Willi syndrome and their families, many people have contributed to this, and of course funding, particularly from the FPWR, but other people, has been so important to us. So thank you very much for listening. I'm sorry I've just gone a little over time, and I'll be very interested to hear your questions.
Thank you so much, Dr. Holland. It's always, I love hearing you talk. I love hearing about VNS and all of that. So we have a lot of questions, so we'll try to go through because I know we went over a little. So let's see. The first, I had two questions coming that were similar, so I'm going to kind of put them together. So one person asked, is there a link between UPD with autism and mental illness later in life? Is the risk for mental illness higher in this population and lower than those who have UPD without autism?
No, that's a really interesting question. I think the evidence is that autism is higher in those with UPD in general, and psychosis is higher with UPD. My suspicion, and actually, I'm trying to think whether anyone has specifically looked at this, but I can't recall that they've looked at whether the two coincide together. It wouldn't perhaps surprise me if that's the case, but the answer is I don't know, and I don't know if it has been formally looked at. Someone may be able to correct me about that, but I don't think it has.
Great. Our next question is, to what extent does anxiety play a role in skin picking?
Right. Now, anxiety in the International Prader-Willi Syndrome Organization Mental Health Network, we've discussed anxiety a bit, and there's a lot of consideration. But does anxiety mean the same thing when we talk about it in people with Prader-Willi syndrome? And I think sometimes, of course, we make assumptions about anxiety because of the way we see someone with Prader-Willi syndrome behave. They're agitated, they're a bit distressed. I think the answer, so I think first of all, I haven't really answered the question yet, but I will, I hope. But I think first of all, we just have to be a little careful what we mean by anxiety. But I think anxiety, as we mean it for people with Prader-Willi syndrome, is a factor in Prader-Willi syndrome. But I don't think that necessarily means that agents that are prescribed for anxiety will make skin picking better. That's the point I'm trying to make. I think we can't say, well, if anxiety is part of skin picking, then let's use an anti-anxiety agent. I don't think that is right.
That makes sense. You had mentioned this medication. This person wanted to know how effective is Riprazole in treating anxiety with children with PWS.
Yes. I mean, I suppose it's been used a lot, I think, in people with autism and who have anxiety and are agitated. And I think there is a place for it. I think, again, one of the things we struggle with in the field of Prader-Willi syndrome is that we haven't really done the trials always that would allow us to definitively answer that question. But I think that it is part of the armory that you might use, if you like, particularly where you think the evidence suggests that anxiety is a major problem. But a lot of anxiety in Prader-Willi syndrome, I think, is situational. And I think risperidone is really not so good for that sort of more situational anxiety. It's really there for more generalized anxiety.
That makes sense. Our next question is, my son, age 9, struggles with speech. And when he went on Celexa medication, I noticed his speech got better. Does anxiety affect speech? And once the anxiety is better, can I expect to see speech increase, or could have the increase in language with medication just be coincidental?
Again, another really interesting question. I think the answer, I suppose, strictly is I don't know, except I think what one can say, and this may be true for speech, but it's certainly, I think, true for sort of cognitive abilities, that if you've got someone who's already impaired in a particular area of mental function, maybe speech or communication or cognition in some way, and they get anxious, then they're going to be more impaired. And I think you see this, that I think we can imagine people with Prader-Willi syndrome as being a bit on a knife edge. So it does, you and I have a certain amount of resilience. We can tolerate a certain amount of anxiety and still have the mental faculties to deal with the issues. But for someone with Prader-Willi syndrome, they just maybe tipped over the edge very quickly by anxiety or by some change in the environment. So I could see how that if you did improve the anxiety, you might improve, in this case, communication or language. But again, this is a very interesting observation. But we don't really, as I know it, have the evidence to really know that for certain. But I could see how it might help.
Yeah, that makes sense. Great. Our next question is, I have used CBD with my daughter, now almost 10, when she gets so upset that she says she can't stop crying or some other indication that she is not in control. Every time I've used it, it works almost instantly to calm her. I know others have had different results. Can you speak of this? Do people respond differently to CBD? Could it be placebo? Are there studies that are looking to CBD?
Yes. I mean, again, I think this is a very interesting observation. And I think if you see something having such an immediate effect, one has to question whether it is having a strictly pharmacological effect. Because if you think about these medications and you think about what you're trying to treat here, you're trying to treat something that is based in terms of brain function. So the medication has to not only be absorbed into the blood, it then has to cross the blood-brain barrier, because there's a barrier between the brain and the blood system. It has to cross that to get in the brain to have an effect. Now, some medications may have a peripheral effect, but I don't think that's the case here. So when you hear of an immediate effect, I think what that might be doing is that sometimes I think it's sort of helping the person pull together their own resources in a sort of placebo way. It isn't, there's a danger that we see placebo as a negative thing. It isn't. It's the person's own resources being almost stimulated by the actions that you're taking. In this case, giving them the medication. I think what would be interesting is, and whether this is ethical, you can think about, but if you had a tablet that looked exactly the same but was inert, and you gave it, I think I would predict that you would get the same response, because it becomes an indicator that things are going to be okay. I can control my behavior. And this is the way that, for example, I think Kate Woodcock has tried to look at managing change, is to use a change card. It's an indicator that says change is going to happen, but it's going to be okay. And I think that's an interesting psychological approach. Great.
Okay, so I have a few questions on VNS. The first question that someone sent in was about Valsalva maneuvers can stimulate vagus nerve. Is this helpful?
Right. Yes. I mean, I think there's a lot of. I think first of all, the vagus nerve stimulation is not having an immediate. It's not the stimulation that's going on now, if you like, that's causing the improvement. It's causing some changes in the brain over the long term. So I think we have to think about vagus nerve stimulation as having a lot. It's like taking a medication that takes 3 months to have an effect, if there was such a medication. It's not taking the medication and it immediately has an effect. Because in both our studies, it took at the very least 3, 4, 5 months before we really began to see any improvements. But having said that, I think what it tells us is that interventions that may ultimately modify the impact of stimulation might increase stimulation of the vagus nerve, may have beneficial effects. Yesterday, I was talking to the mother of a 6-year-old with Prader-Willi syndrome, and her daughter's starting to have temper outbursts. I think in her case, it's really an indication of developmental delay, by the way, because they were very similar to what you see in normal development in what in this country we call the terrible twos, if you like. But her mother was saying, I've started massaging for a certain time each day, and I think that's having an effect. And massage may be changing the way the vagus nerve is stimulating. is activated. So I think we need to be much more aware of the mechanisms that work through the autonomic nervous system. And I think that may be very important in Prader-Willi syndrome.
Great. So there's a few more questions. I'm just trying to kind of put them together. So the questions around VNS were, where can we get the device? Can they feel it if it's implanted in them? Are there negative side effects? And are there more studies?
Right. Yeah. Now, first, I mean, to answer the implanted device, just to say, I mean, they're routinely used and will be approved for epilepsy in the States and in many countries in the world. And of course, in theory, they can then be used off-label at the instructions, the guidance of a medical practitioner. But of course, it does require surgery. It is a big, it's a fairly big, it's a relatively minor surgery, but it is surgery. It's been safely used in thousands of people for epilepsy, including people with neurodevelopmental disabilities. You can feel it switches on for 30 seconds, depending on how it's programmed, but it switches on for 30 seconds, off for 5 minutes, on for 30 seconds. And when it switches on, sometimes the voice changes. The person becomes a little hoarse. They can occasionally get hiccups because of it, and a little bit of discomfort. So that's the main side effects. For the external device, which you wear for 4 hours a day, the main side effect is occasionally you get soreness in the ear where the electrode sits after a while, but it's by and large pretty safe. So the internal device is approved. The external device, the device we used is called NEMOS. It's made now by a company in Germany. It's now approved, including for Prader-Willi syndrome, by the European Medicines Agency, but it's not approved by the FDA. So it's going through that process at present. And I know Teresa in the FPWR is very involved with that process and has been linking with the manufacturers in Germany about that. There are other stimulators, but there's great debate about whether they stimulate the vagus nerve or not. These external transcutaneous stimulators are still something in development, and I wouldn't claim to be an expert on them. But you've got to be careful about something that might claim to be a vagus nerve stimulator, whether it is. I'm convinced that the NEMOS is. Whether the other ones are, I'm not in a position to say. But be careful.
Great information. Where could someone learn more about VNS and trying it when it is available?
Right. It is. I think. I mean, people are very welcome to the papers, that second paper, and I'm sure the FPWI will have a copy of that. So I would recommend that you do look at that. I don't think it's too technical or anything, but it'll give you a very clear idea, I think, of the improvements that we noticed. I think there is quite a lot on the internet about its use for epilepsy and other conditions. You might want to look at the work of Stephen Porges called the polyvagal theory. Again, he's written quite a lot of books for the lay audience. And that will tell you his theory about how the vagus nerve evolved and what it's there to do. And I think by reading that, you'll get some understanding of why vagus nerve stimulation might be important and helpful in people with Prader-Willi syndrome.
And I just want to mention Teresa did reach out to me to remind me that FPWR is planning a clinical trial, and we are working with Dr. Holland. So keep your eye out for information on that coming.
Just to say, there is a small trial in France involving children, and a group in Germany hopes to start something soon.
Great, wonderful. Do drugs like stimulants, wake-promoting agents, worsen the psychological activation that may be helped by vagus nerve stimulation?
I think the answer is, again, one can't be certain about that, but I would be concerned that it might.
Okay. How does vagus nerve work compared to integrative listening therapy?
I'm not particularly familiar with integrative listening therapy, but they're interesting. All these things may have a final common pathway in terms of essentially I mentioned earlier the autonomic nervous system consists of the sympathetic and the parasympathetic, and these two work in opposite, but in tandem. The sympathetic drives the arousal response, and the parasympathetic deadens it, if you like. What you want in Prader-Willi syndrome is an increase in parasympathetic, in other words, vagus nerve activity, and a diminution in sympathetic activity. And these sorts of psychological approaches may do that. Yoga may do that, for example. The problem with them is whether they lead to a lasting improvement, or whether you have to continue them or not. But all these things we may find have this final common pathway through its influence on the autonomic nervous system.
Is there any study or discussion around how much more likely a UPD person will have psychosis if there's a family history on paternal or maternal side of things such as bipolar?
Right. I mean, I think first of all, the starting point, I think, would be there's no reason in a way to believe that the same predispositions to bipolar, for example, that you see in the general population might not also apply to someone who happens to have Prader-Willi syndrome. So if there is a first degree relative that has a bipolar disorder, then that will increase the risk. Now, very interestingly, in our earlier study that was published by Sonny and others, she looked in detail at those with the deletion who had psychosis. And half of those who had psychosis had a history of affective disorder on the maternal side. And we've never followed that up in any more detail. But it does suggest that maybe in the case of deletion, a combination of having Prader-Willi syndrome and then what you might call a second hit of having a family relative with it and the genetics that come with that might be enough just to push them further so they go over the threshold and develop a psychosis. And our model of psychosis is what we call a two-hit model. It's having Prader-Willi syndrome gives you mood instability. Having UPD pushes you further and gives you an affective psychosis. Well, if you have a deletion, maybe having a family history pushes you that bit further as well. That's our model, but that model is to be tested really in a more sophisticated way.
Yeah, it's really interesting. Is there anything that can be done in early childhood for a child with UPD to prevent psychological issues later in life?
Right. I think, and this comes back a little bit to what I mentioned around IQ, that I think one of the really interesting things is that, of course, we are seeing a whole new generation of young children with Prader-Willi syndrome who will, almost all of them will have been diagnosed certainly within a few weeks, almost within a few days of birth. They will have been started on growth hormone early in life. The families would have been fully informed about what to expect, how to manage the eating, and so on and so forth. And early childhood will have been rather different for them. So I think the truth is we don't know whether that will protect them from some of the psychological and psychiatric problems of later life. And I think we should keep an open mind about that. We do know there's evidence from some European studies that growth hormone, for example, does improve intellectual functioning a little bit. Maybe all these things just have a relatively minor effect, but just enough to make a difference. We have to wait and see. We need to do more studies on this younger generation as they get older.
Yeah, definitely. What in the moment strategies are successful during an episode of elevated anxiety and questions?
Right. And if one talks about elevated anxiety here, I presume one's talking about sort of emotional outbursts as well. And I think that, of course, the general teaching here, and there would be psychologists and others who would be a bit better versed than I about this, but the general recommendation is, if of course it's possible, is that you don't seek to engage in trying to rationalize at this time. I mean, what you need to do is have an agreed strategy that ideally has been agreed at times when the person's been calm, and that you, and if there's two of you, husband and wife or whatever, agree to a strategy. So there's some certainty, there's some agreement as to, and routine as to what should happen. And usually that is saying to the person, I'm going to just back off now, and I want you to calm. You know what you need to do. We've agreed this. And when this is all over, and when you feel calm and able to do so, we can think again. Could you have managed it differently? Could I have done something differently?
Mm-hmm.
But it's the, and I say this advisedly, being male, that sometimes I think men are worse at this, because the men sort of, they want the person to say, look, I apologize, I shouldn't have done this. When actually they're not in a position to do that. They're getting out of control. They're feeling awful.
Mm.
And we know that when it's over, often they're very distressed and upset by this. It's not, in a way, it's not their fault. So you just want to try and it's easy for me because I don't have to be there. It's harder for you as parents, but in a way, if you can remain calm, then they will calm. If you have routine, they will be able to latch onto that routine and use it as a means of calming, much in the same way as your person described giving the tablet, that which seemed to sort of allow the person to calm.
Yeah, no, I have an 8-year-old, and when this happens, we have a routine of, okay, we're gonna deep breathe and we're gonna get through this, and then yes, once we're removed and from it, then we talk about what happened. And
absolutely.
So yeah. There's one last question. I wonder if autism diagnosis in PWS by deletion is sometimes overlooked and attributed to just PWS in general. My son was formally diagnosed with autism at 12 during a formal neuropsychological evaluation. I guess there wasn't a question. I think she's just commenting that it's often.
No, I think that's a really interesting issue. And I think one of the problems is, of course, we think of autism as a category. And we think if you fall this side, you have autism. And if you fall that side, you don't. But with these complex neurodevelopmental syndromes, it's not as simple as that. But the way DSM or ICD thinks about them is you have it or you don't. And of course, people may have part of it, but not all of it. And of course, in this country, if you're to get services provided for people with autism, you need to meet the categorical diagnosis of autism. It's not good enough to say you have 2/3 of autism, but not that last third, if you like. And I think that's a problem, actually. I think we should be thinking much more dimensional about these things.